And welcome everybody to this roundtable discussion. I'm Catherine Bouvier, and I have worked closely with people living with neuroendocrine cancers for many years, both as a specialist nurse and as a patient advocate. Today we're going to be talking about a group of cancers known as neuroendocrine cancers, with a focus on the neuroendocrine tumour group. We're going to look at what they are, who can be affected, how people live with them. This group of cancers has long been considered rare, but now they're being diagnosed more frequently as awareness and detection improve around the world. We'll also talk about a treatment called Radioligand Therapy, or RLT. It's actually often known to the neuroendocrine cancer world as PRRT, or peptide receptor radionuclide therapy. But if you've never heard of either of those, please don't worry. We're going to make it all clear and easy to understand. So let's start. Let's start with providing our audience with a clearer picture, really, about what exactly neuroendocrine cancers are. And if it's okay, if I could turn to you first, Professor Van Dam. Not a very simple question, but really it'd be wonderful if you could explain what neuroendocrine cancers are, but really showing the differentiation between neuroendocrine tumours and neuroendocrine carcinomas.
Thank you for the question. I think it's a very important one, because when you think about neuroendocrine cancer, we think about a very different kind of cancer than many other cancers. And the reason for that is because they originate from the neuroendocrine cells in the body. And those neuroendocrine cells in the body are actually the regulators of many body functions. And therefore, because they are important, they are also spread through the body. So there are many neuroendocrine cells in the body, and that means that there are also many places where neuroendocrine cancer can appear. Mostly, however, we see those cancers appear in the lungs, in the small intestine, and the pancreas. So that's where we will mostly be focusing on today. And when we talk about neuroendocrine cancer, we see that it's actually divided in two large groups. One are the neuroendocrine tumors, and the second are the neuroendocrine carcinoma. And I would like to start with the neuroendocrine carcinoma, because neuroendocrine carcinomas are very aggressive tumors that unfortunately are impacting patients' life quite importantly. And we know that this kind of cancer unfortunately often leads to the demise of the patient. On the other hand, there is a neuroendocrine tumor, which luckily is 75% of all neuroendocrine cancers, where we have a more indolent disease course. However, this disease is still very impactful for the patients, and even with current treatment, we do see patients that demise due to the neuroendocrine tumor.
No, thank you so much. And I think you're right. It's very important to make that differentiation. One of the things that is quite frustrating within our community, and I'm sure it's something that Dirk will agree with, is the time to diagnosis and how many patients take many years to get diagnosed. You've alluded to the fact that patients often have non-specific symptoms, so that can be a hurdle in itself. But why else do you think this is continuing to happen? I think we've improved slightly, but it's still a matter of years, not months or weeks.
Yeah, I think one of the main points there is awareness. So as you said in your introduction, neuroendocrine tumors were considered to be rare tumors. I would say this has changed. Over the last decades, we see a steady increase in the diagnosis of neuroendocrine tumors, and I would now call them rather uncommon than rare. And it's even the fact that today, the second most common malignancy in the gastrointestinal tract after colon cancer is actually a neuroendocrine tumor. So there are many patients living with NET. However, because of those idea of rarity, it's not on the top of mind of many physicians. So they are not taught as much about neuroendocrine tumors in medical school. And of course, there are many other more common diseases that they think about when a patient presents in their consultation room.
So education is really key, as is awareness and recognition, I guess.
Absolutely.
Okay, thank you so much. So now we're going to look at one of the promising treatments that are available for the neuroendocrine cancer community for the appropriate patients. And this is something called radioligand therapy, or RLT. And as I mentioned in my introduction, a lot of people within the neuroendocrine community will probably know it as PRRT. So can I just turn to you, Professor Jaleb, to just help us and simply describe what RLT is?
So RLT is a treatment, a systemic treatment that we are giving to patients in nuclear medicine. The principle is we have a vector, a probe, who will just target specifically one receptor in the cancer cell. The principle is we're going to target the cancer cell, so that means we will not target the normal tissue. And for the radioligand therapy, we have different phases. The first phase is imaging. So for imaging, we are using one isotope that can allow us to detect where the cancer cells are and if the receptor is present or not. And when we know and we establish that the receptor is present, we can change the isotope, and we can use an isotope that can deliver some radiation and destroy cancer cell. And the treatment is going the same way and is going to target specifically the receptor the same way, and is just going to deliver the radiation to the cancer cell.
Thank you so much. At what point is RLT usually considered? I mean, is it ever considered as a first-line therapy, or is it always somatostatin analogues first? And how do you decide whether someone's eligible?
It's the second line of treatment. It's for a non-resecable metastatic disease of the intestinal. So that means you cannot just do surgery and remove all the disease. So you cannot remove it, and you have to go to a systemic treatment. And it's the second line after somatostatin analog. So to choose if the patient, when it's time to go to the second line, can have radioligand therapy, we do the imaging. Most of the time it's the gallium-68 DOTATOC, and we see if the expression of the SST2 receptor are enough to go to the treatment.
Okay, and not that you're all not very important, but I think the most important person here in the room is Dirk, who is living with neuroendocrine cancer. So I just want to turn to you really and ask you if you've seen any benefits of the patients in your community when they've received RLT, or whether people have struggled with it, or whether you're seeing increases in energy or quality of life from your community that you work with in Belgium.
Yeah, definitely. In my close range, I mean, the members of our organization, we have dozens of PRRT cases. All the majority is either they have a little bit of nausea 1, 2, 3 days after the injection, or nothing at all. And sometimes, and this really touches me as a close friend of mine. I thought she wouldn't make the end of the year. She had the PRRT and she went on 2 cruises the next year. The metamorphosis was fantastic. And I spoke with her, I spoke with her husband, and they say, we know we are not cured, we're not healed. The disease is still in the body, but the quality of life is going sky high. And as I says, well, we live by the day now and enjoy as much as possible.
But, just thinking about, living again with this sort of incurable disease, it can take its toll, probably psychologically quite a lot too. Do you see that within your communities?
Yeah, definitely. It's Damocles' sword is hanging above you. I have 2 scans a year, a normal PET scan and a DOTA scan with a variation of 6 months in between. And every time I go to the consultation after the scan, it's going like getting your school report.
Yeah.
Which was, in my time, also very exciting.
Do you get nervous before your scans?
No, before the consultation.
When the results come.
Yeah.
Yeah.
I know the scans now. It's nothing. But the consultation is always, you have the take in, they say, how are you doing this? And they say, cut it. They say, how is the test? I want to know this. And then we continue. Yeah, I'm nervous. It's 14 years long, every time. Yeah.
Well, it takes its toll, doesn't it? So,
yeah.
One interesting part is within the last 15 years, the scan really changed. Before it was octreoscan, and the exam lasts between 2 and 3 days, and now it's like 60 minutes. So it's completely changed the way we can assess if there is a sign of neuroendocrine tumor, for example.
And it's much more accurate.
And again,
and more detail.
Yes, exactly.
I was declared cured after the octreotide.
Yeah, and that was a misreport.
No, I just didn't see it. The tumors were too small, and the DOTA-TOC or DOTA scan, they can see the really small tumors. The
So when you
octreotide
had one
doesn't.
after the other, I mean, that must have been quite a shock.
I was lucky because I spoken to one of the nuclear specialists who was going to do the test, and he warned me. He said, if you're declared clear after an octreotide scan, I say, don't get too shocked if the DOTA-TOC shows tumors, because they could have been already there from the beginning. So it's not new tumors, and new tumors is metastasis and is tumor growth, which is a lot more worrying than having the tumor sleeping in your body, right?
Lara, not last but not least, obviously, but I'd love to just turn to you with your expertise, because we need to think about access challenges, don't we? And the fact that this treatment isn't available for everybody, and the diagnostic scans are certainly not available to everybody worldwide. So from your experience, what do you think are the main barriers to access for RLT? I mean, globally, I guess I'm speaking. And what do you think could help more patients benefit from it, regardless of where they live?
Well, that's a very global question, because I think according to where you are, you're going to have to face different problems. In general, increasing awareness is definitely good anywhere. At the medical point of view and at the patient's point of view, at the general practitioner point of view, that will always help. And it is very important that we take this awareness, because we are all privileged on being in some of the centers where we are working, but a lot of patients are out there in the middle of nowhere, and they are still patients. So we have to do a lot so as to be helping them or reaching out to them so as to make it easier for them to have access.
What is important indeed is that we make our healthcare system ready for this next generation of treatment. I mean, radioligand therapy sometimes feels a little bit of science fiction, but it's here, and it's here to stay. And I think we will be treating more and more patients with radioligand therapy. And what I would feel very poorly about is if we would have amazing treatments, but we just cannot get them to our patients because we don't have the necessary infrastructure, we don't have the people, because that's also important. You need to have the people that know how to work with these new therapies as well. And that would be such a waste if we cannot do that. So we have to be ready for the next generation starting today, because we are treating a lot of patients today with this treatment. And I think access is very important. This is, as we have said before, a powerful treatment. This is a treatment that is very well tolerated, and I think it's going to be used far, far more in the future.
No, thank you so much, and thanks so much all of you for your wonderful insights and for your time, and for a really meaningful conversation. I think there's a lot to say, and we could probably talk for a lot longer. We've heard that these cancers are complex, but we've also heard about innovative treatments that are here now and have hope for the future, treatments like RLT. And that is what the Oncidium is all about. It's trying to raise awareness of RLT and to improve access to this treatment globally.